Hi everyone, good evening. I am Deborah Marchetti, the founder of Flor da Vida, and tonight we are having this amazing class with Dr. Jill, Trauma-Informed Care in Maternal Health for Birth Providers. And I'm so glad that you are here. And if you're catching the recording later, please feel free to drop a message for us. And if you are watching here live, you also gonna have a chance to ask any questions later on. But Jill is going to work walk you through how the event's gonna go for tonight. So Jill, welcome and thank you so much
Yeah,
for being here with us tonight.
thank you. Thank you for hosting. I really appreciate it. And thank you for everybody who signed up. So this is going to be, it was scheduled for 2 hours. It may actually be a little shorter because everybody is virtual today. Initially, we offered virtual and on-site at the center in Verona. But since it is virtual, it may move a little bit quicker. So get you out of here a little earlier tonight. But of course, if anybody has any questions, I'll stay on a little bit longer. And as Debbie said, email if you're not on now, if you're watching it recorded, and to let us know. All right. So with that, we're going to go ahead and get started. Welcome to Trauma Informed Care in Maternal Health. And first, we're going to go over the agenda. Um, we have 8 sections today. We're probably going to stop for a little bit of a break after section 4. So if you need to, get up to have something, tea or bathroom break, feel free. I mean, even if you need to get up in between, again, this is being recorded, so you won't miss anything. I'm going to start with our intros, and then we're going to move on to ACEs. Some of you may be familiar with ACEs. Some of you may not be. And so we're going to go a little bit more into detail about that and how it matters and how it matters to your clients. We're going to define trauma and then look at trauma from the perspective of the brain and neurocognitive development with the people that you're working with, as well as issues that they may have gone through when they were children. So, not even during the birthing phase. Then we're going to go a little bit more specific into trauma in the perinatal period. We'll go over providing trauma informed care, and then we'll talk about self care and boundaries. We'll finally wrap up, have questions, and again, if anybody has anything outstanding that we didn't cover, want to ask about, feel free. All right, we'll move on. And intro. So I know some of you are watching later for recording, and some of you are not able to talk. You may be in a car or what have you. But if anybody would like to speak up and state your name, you can share your background. We always do this, especially in the live webinar seminars that we do, because that way it's good for people to meet. It's good to get to know everybody, kind of like build your whole birth family. So whoever would like to go first, I guess we've got, is it Debbie? I can't see everybody. It looks like Patrice and Emily are the only people on there is that correct?
Patrice and Emily, yeah, for now.
Okay, great. So then we'll start with Patrice.
I'm already in my PJs, so that's why I didn't want to turn my video on.
Ah, no worries. You don't have to.
No, I know.
Get comfortable.
Just wanted to say hello. I'm Patrice Payment. I am in Roswell, Georgia. I'm an LPC, and then I also have PMHC. I do perinatal mental health only. I only work with moms, so kind of moms across the lifespan, but I specialize in perinatal mental health and anxiety, new moms with anxiety. So I'm just interested because, I've done some trainings in trauma, but I feel like you can never have enough just to be more informed, and that's pretty much it. Just excited to hear your take on it.
Thank you. Welcome.
What
Yeah.
learn about the event, Patrice?
I think one of you posted it in the perinatal mental health professionals Facebook group.
Yep, that was me.
Okay.
Yeah.
Yeah, and I was actually looking that day, like counting up my hours I have to renew in October, and I was like, well, I need some hours, and this sounds interesting. So, yeah.
Perfect. Great. Well, happy to have you.
Thank you.
Okay, next we've got Emily.
She wrote on the chat. I'll read it.
Okay.
She's a doctor of physical therapy, a doula. As a new doula, this is important to me so I can navigate birth trauma and be better able to help moms navigate all the new trauma so that it doesn't turn into PPDA.
Mm, important. Good. Well, thank
Emily.
you. And glad to have you. Welcome.
Oh, into
And
the
Crystal. Oh, I
sorry,
saw
she.
Crystal came up and then it disappeared.
Oh, okay. Maybe she's having problem connecting.
Mm,
Emily also says that you can never have enough trauma training, and it helps us looking inward to make sure we don't carry anything with us into their labors, which is something we talk a lot here in
absolutely.
sessions,
Uh,
right?
you know, and throughout your entire life too. It isn't, just uh, during the perinatal period, but as a parent, as a child of a parent that may have had trauma. Again, these are important things throughout our life, and sometimes we forget about it. We're like, oh, we don't have to work on this. I healed my trauma. I've moved on. I've done therapy, and then years later, it comes back to quote unquote haunt you because something occurred in your life, and it's important to address it and not just push it away and say, "Oh, I've dealt with this before, and this was a trauma from when I was 10." It shouldn't bother me now that I'm having a baby or what have you. But as we know, those of you who are in mental health, that sometimes that's what happens. That becomes a trigger. All right, let's move on to my introduction. Which should be right here on the side if it wants to move. Canva is being slow. There we go. um, hi, my name is Dr. Jill. I am a public health doctor. My clinical concentrations are in maternal mental health, perinatal epidemiology, and psychiatric epidemiology. I am also a doctor of Indigenous medicine and certified as a functional medicine provider. I am a certified clinical trauma specialist and I've been working in trauma for about 15 years. I have 3 teenagers. I also work in William Patterson University as a public health professor and an instructor with empowering midwifery education. And I myself am a trauma survivor. I also am board member for New Jersey's Postpartum Support International, PSI, which is a good, if anybody hasn't heard of it, again, PSI is a very good resource. We have chapters all over the world, not just in the United States. Bottom left here, you can see Debbie as well in the middle. That's one of our events at Florida. And I apologize for how slow this is. We're going to first talk about ACEs. So ACEs, if you are not familiar, are adverse childhood experiences. And this was a scoring that was done years ago through the Department of Health and Human Services. And SAMHSA, as part of the Department of Health and Human Services, has done extensive training for providers and practitioners on ACEs. And they've also done extensive research and studies on how ACEs will make a difference in a person's life and how they can have long-term consequences, even if it's something that happened, to a child when they were 3 or 10, such as physical, emotional, sexual abuse, neglect, different household dysfunctions. And so we're talking about in the household and also environmental, living in an area where it may be unsafe to go outside. Also seeing, witnessing substance abuse, not necessarily being part of it. Also physical abuse. Being part of it is one, but then also you'll see later I'm actually including one of the ACEs scales. And different things will matter for different points. Again, it's been studied that an individual who is being abused has been looked at a lot. But with ACEs, we also say an individual who sees abuse, witnesses abuse, and that is pretty significant. And sometimes that's forgotten, which is why it's important to go through the ACEs training and work with, whether you're a doula or lactation consultant or, physical therapist, work with your patients and to understand where they're coming from. ACE scores, you'll see on the next page, they range from 0 to 10. And that reflects on the amount of trauma experiences really that are documented. Of course, everything's not documented, but this is kind of, an average from the research that they feel indicates you have initial trauma, long-term trauma, again, the consequences that can come from this, especially without being treated, especially without, as we'll get into, protective factors. Risk factors are higher, it's going to cause these higher ACE scores to be more of an issue. The research has actually shown that higher ACE scores have not only affected individuals' mental health, social health, but also physical health, chronic lung disease, cancer. A lot of emotional and psychological abuse and trauma has been linked to not only depression and anxiety, but also substance use and substance abuse, and abusing children, like following suit and becoming an abuser, unfortunately. Sometimes clients can go either way, become very paranoid of ever hurting a child. Others can go the opposite way and, as I said, become abusers themselves. So, ACE scores, they can help as a tool. Again, everything we know when we do scoring and tests and measurements, it's a tool. It's not even if it's a diagnosis tool, it's still just a tool. It'll help you in your toolbox when dealing with your patients. And so this is something that can help people as a whole, can help, and I'll say from a public health perspective and an epidemiological perspective, it really helps for developing prevention intervention strategies when you get to feel a little bit more about the population, what they're experiencing and what can help them, learning how to most reduce the risk. So ACEs, going too fast. They're common. Approximately 16% of the adult population report 4 or more ACEs. And so, what is that? 209,128,094 people. 16% seems small, but when you think about it, and we're talking about abuse, and we're talking about one, people that actually report it, and 2, 4 or more ACEs, because that's what's considered significant. So there's a lot going on, and even though it's common, that doesn't mean it's okay. They also can be passed from generation to generation. You may have learned about different types of neurobiology and how some things can be passed on, including toxic stress and the way that the brain is actually growing. neurocognition, initial development, brain development, especially if it's something where the mother or the pregnant individual is being abused during the development of the embryo, the fetal brainstem. A lot can directly affect the brain development. And again, it can be passed down. So parental and child from the neuroendocrine, immune, metabolic, and genetic or genetic regulatory function. So again, if you're interested in more of the science about this, I do have resources at the end and some of the citations. So if you're interested in reading a little bit more about that aspect of it, you're welcome to do so. But for the feeling of this particular training today, we're just going to lean on the fact that, yes, it is passed from generation to generation. I won't go into detail too much about the brain development, but knowing that can help you reduce the risk, can help you educate your patients, help you educate your colleagues. Something that can make a difference. And this is why it's so important. It's not one of those things where you just ignore it and it'll go away. ACEs also have a cumulative effect. So cumulative adversities do result from maltreatment. So those are the direct adversities. And as I had mentioned before, the indirect. So the direct, if somebody is getting abused, the indirect, if they're seeing somebody get abused, or, family dysfunction. This, again, it's a good indicator of a disadvantaged situation and the things that can make it worse. So, for example, if they're in a strong, healthy environment, they have those protective factors that will help protect, essentially, from the other adversity. If they have more risk factors, it's not going to cause it directly, but again, indirectly, more risk factors will lead to more severe consequences from the same type of trauma. And then finally, I think this is the most important thing, because I'm saying all of these negative things, they are not destiny. They're facts, but they're not fate. It happens. And if you are working with somebody as a doula, I believe all of you are training for be a doula, and in working with your patients, if something had occurred in one of the mom's past, know that this is not their destiny. Even if they share with you that, they were abused, or, they're not sure how to, or they want to breastfeed a baby because they may have been sexually abused. Maybe they're not sure even about having kids at all because they don't want to yell at their kids the way they've been yelled at, et cetera, et cetera. So know that you can break the cycle. It's not fate. Just because you've had these experiences in your lifetime, it does not mean that you're doomed to repeat them. It does not mean that this is your destiny. These moms are absolutely able to heal and to move on. So as I mentioned before, with the Department of Health and Human Services scale, CDC as part of HHS, and I will note this was CDC 2019. I apologize for the extra 2 in that bottom right, but this is 2019, not 2021, when they pulled these numbers. From an epidemiological point of view, it has, from 2019 to now, the difference is not significant, but the amount of ACEs is actually increasing with the population. As I noted, having ACEs in somebody's history can cause mental and physical issues. And, I explained some of the physical issues before. Now you can actually see some of the numbers. COPD, it's significant. risk higher. Sexually transmitted infections, the reason that that's so high is that it is more likely for somebody who's experienced ACEs to be in unsafe sexual situations. Smoking, cancer, heart disease, suicide attempts, alcoholism, and using street drugs. Again, a lot of this was kind of obvious because you think, okay, they're in a situation where they're being abused and looking for, self-medicate and what have you. It's not always the case, but statistically, this does tend to happen more when people have trauma in their past and in their situation. So environmental trauma, emotional, psychological, physical. And here's the ACE questionnaire. So some of you I know have seen it before. Some of you may have never seen this, but referring to the actual questionnaire to get the ACE scores, it is available online. You can go through the CDC website. You can ask me, I can email it to you. You can search for it. Just make sure you're getting the accurate one. The real one, not like magazine version or TikTok version. And I don't have to go through every question now. I'm checking for time. But again, it's essentially, were you abused or did you see abuse? Did you witness abuse? Did you live with an alcoholic parent? Did you live with somebody who went to prison? Were you injured? Did you see somebody get injured? Were you physically, sexually, emotionally abused? Emotionally is in here too. Did somebody humiliate you, swear at you, insult you, or put you down? Act in a way that you feel hurt. Again, these questions, each one is a 1, and then when you add them up, it's very easy. No, there isn't a scoring table. Essentially, it's just adding them up, and over 4 or 5, it's considered trauma. So we're going to define trauma a little more. Did anybody have any questions about ACEs before we move on to 3? Okay, we're going to move on to 3 then, and actually define trauma. So being traumatized, or not actual trauma, but traumatic stress, it's an illness in the DSM-5 of not being able to be, quote, fully alive in the present. Now, that's a quote from Dr. Vanderkolk. You may have heard of the body keeps the score. It became popular in the last couple of years. But I like this quote instead of just pulling something from DSM-5 because it feels like it envelops the whole feeling of what it is to be traumatized or to have traumatic stress. You're not able to be fully alive. You've got your poor little amygdalas going like, something's wrong the whole time. And you're like, no, I'm fine. There's nobody that's going to hurt me. My abuser died 20 years ago, or I moved away, or what have you. But your brain is still going to be on edge. And it's hard because, again, you can't be fully alive in the present. Trauma, when there is trauma, we have, a distressing situation, a frightening situation. HHS says that there is an event, a series of events, a set of circumstances that it's experienced by that individual. These experiences are physically and or emotionally harmful or threatening to that individual. So this is a very important point because sometimes people say that's not really trauma because you had an emotionally scary birth. That can't be birth trauma. Trauma has to be physical. No, it's physical or emotional. It could be threatening. It can be something that has lasting adverse effects on an individual that may not be something that the doctors think is trauma. I've actually worked with a lot of people that have said, they had a hospital birth and their hospital birth was by the book, perfect. Okay, good. You got a baby, you're healthy, the baby's healthy, and they still feel traumatized. And that is real. And that needs to be addressed and it needs to get the same respect as somebody who may have had, a infant loss or they lost blood and were in the hospital for an extra week or what have you. I mean, that's trauma as well. This all deserves the same respect to the individual going through it. Because again, trauma can be physical or emotional, be social, be psychological. It could be, as we were looking at those ACEs before, somebody who humiliates you, a physician may make you feel humiliated and tell you that you don't know what you're talking about or what have you in a birth situation, and that may lead to the patient feeling as though their individual functioning, their physical, social, emotional, spiritual well-being is affected. Anything that is affected, and that has those long-term effects should be addressed. That is okay to tell that individual that you have had a traumatic birth and we can work on that. Maybe your next birth will either, focus on how they are now to heal if they had just had the baby, or if you're working with somebody who is pregnant and, planning to have their next baby, again, just knowing this, being trauma informed, being able to approach the situation with that trauma informed lens will help reduce the risk of this happening again. Pierre Levine, another author here who's also a biophysicist and psychologist, said that trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of human suffering. And I like to focus on each word of that sentence because it's true. People avoid it. Nobody wants to talk about trauma. Nobody wants to talk about, certain things that make people not look like they had a perfect birth. Sometimes it's misunderstood, which again, when I was talking about, it has to be physical trauma. No, it can be emotional. It can be psychological, which causes this misunderstanding, causes a lack of treatment, which leads to suffering. Not to sound like Yoda or anything, but it does. It's that whole line where this is ignored, and then this is because it's ignored, it's untreated. Because it's untreated, then you end up suffering for it and potentially passing it down to the next generation or the people around you. And so that's why it's extremely important to address. So who does it affect? I know we are talking about birth, but we're also, as a whole, being affected as healthcare practitioners and professionals, which is the service providers, the individuals themselves who experience the traumatic events, witnesses often of traumatic events are also affected, and public health as a whole. It has a significant effect, can affect generations, can affect specific cultures, families, groups, communities. It can affect, depending on what the trauma is, people of a specific sexual orientation or specific gender, of a psychosocial background or geographic region. Again, depending on the focus of that particular trauma. So everybody can be affected. Nobody gets away. Not that everybody has trauma, but everybody can be affected by trauma. So let's talk a little bit about the different kinds of trauma. So you will probably run into All of these, um, they're statistically, if you're a doula, birth worker, you may run into all of these. One isn't heavier than the other in that particular community. So, your acute trauma, your chronic trauma, and your complex trauma. Your acute, single incident. Something happened. It was somebody was shot, or it was a really bad birth, or a dog got hit by a car. This is a single incident. Chronic trauma is something that's going on for a long period of time. It doesn't have to be forever, but it's just prolonged. So you got domestic violence, sexual abuse, childhood abuse, things that are going on again, repeated and prolonged. And then there's complex trauma, which exposure to varied and multiple traumatic events. So complex trauma is different levels. It may be different types of traumatic events that have occurred over time. It may be in a traumatic situation when another traumatic event occurs. So let's say like refugees or an individual who's homeless. This is already a trauma. And then on top of that, they're sexually abused. You can have an acute trauma that occurs on top of a chronic trauma, but ends up getting diagnosed more like a complex trauma. Again, this is something that as a doula wouldn't be working directly with, but indirectly, it's very important to know the different types of trauma and how it comes across, and how things that may be traumatic to an individual. Examples of trauma. So the reason that I've included this is that, yes, as I mentioned before, anything can be a traumatic situation to an individual, depending on how they deal with it, how they feel about it, and then how they feel after. But some of the most common examples of trauma are natural disasters, sexual, physical abuse, domestic violence, medical injury or medical illness, long-term illness, violence in the community, neglect, deprivation. So this could be, being neglected as a child, or just being in a situation of low socioeconomic status where deprivation is causing an uncomfortable living situation. Being mistreated in childbirth. Again, that is a big one. Being a victim of a crime, kidnapping, accidents, violence at school, and also experiencing a loss or a death. So, having somebody die, having somebody that leave, like a divorce, parent that you're close to, all of these are examples. Now, understanding re-traumatization is especially important for those of you that are working with women that have been traumatized. As a doula, you are with them for their birth or for their baby, depending on whether you're a birth doula or a postpartum doula. And they may, while you're with them, have a situation where they're being re-traumatized. And that's when a situation, attitude, interaction, or environment. So where they are in this environment is important, because sometimes people choose not to have a hospital birth because the first birth was traumatic for them. And when they're in the hospital the second time, just walking in the hospital reminds them of that negative situation. And it could be an interaction. It could be something that a nurse says to them, or just an attitude. But when this occurs, this situation that replicates the events or the dynamics of that original trauma that occurred, it can trigger those feelings again. And it can trigger the actual reactions that are associated. It may be obvious. It might not be. Sometimes somebody can be re-traumatizing somebody unintentionally. This happens a lot with breastfeeding, for example, as I mentioned previously, somebody who has sexual abuse may associate the breasts with that abuse. And when they nurse, it's a different type of feeling. So a lactation consultant may unintentionally re-traumatize somebody. So it doesn't always have to be intentional. It doesn't have to be, oh, I'm with the same doctor who called me such and such. Um, it could be just something that you don't know about. But again, that's why it's important to be trauma informed, because you approach the situation differently and you allow your patient or your client to explain to you, I don't like that. Those bright lights make me uncomfortable. That's fine. You want to stay clothed when you're in the water to birth your baby. That's fine. Wear a bathing suit or at least on the top. The thing with re-traumatization, though, third bullet point is it's always hurtful. So even if it's not meant to be, even if it's not obvious, if they feel as though they're re-traumatized, then it is a hurtful feeling, and it's something to work through. And see if it's true. This is what we want to look at for using the 3 R's of trauma. We want to, stop that cycle and focus on the soothing aspect. So starting with regulate, relate, and reason, starting with, the whole process of the R's to get them through without causing additional traumatization. So with regulate, soothing, breathing, because as I mentioned before about the amygdala, the trauma will put them in those lower parts of the brain. So you can't exactly reason with somebody. You can't talk through it at the beginning. It's a traumatic, I am worried, amygdala, blah, 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 is going off. I can't hear anything. All I can see is this red light. I'm scared. I don't know what to do. I can't necessarily verbalize it. It's just that is what's going on. They're in that lower part of the brain. So again, don't try to reason at this stage. Calm, soothing, safe. Once an individual feels like they're at that point, they calm down. You can talk with more short sentences, validate their feelings. As I noted before, everything is important. So if they feel as though they were traumatized by something somebody said, don't discredit it. Oh, that doesn't mean anything. It means to them. So you can validate their feelings. Make sure your tone of voice and your words are supportive. You're providing them with physical support if they want it, a hug, hand holding. If they don't want it, then, again, just saying, okay, well, I'm here if you need me, and I will talk through this with you. And then finally, once we get to the calm part, once we're regulated, then you can reason with them. You can talk about coping strategies and coping skills and grounding and mindfulness exercises and different things that now the brain can process. And so they can work through and then reach those tools and use them again at another time. All right. Halfway through. So we're going to discuss the brain a little bit. As I noted before, I'm not going too much into the science aspect. We're just going to talk a little.
Sorry to unmute, but you muted yourself, Jill. We can't hear you.
I'm sorry. Can you hear me?
Yes.
I tried to move my window open so I can see the slide, and I must have clicked mute. I'm sorry. I'll backtrack to the beginning about the brain. As I said previously, we're not going to go into too much detail about the science of it, but from your perspective of dealing with your patients and your clients, understanding the fact that trauma is actually disrupting the brain, it's disrupting brain development, balance, and can continue to get worse without treatment. And it can be triggering. It isn't just something somebody can, think through, okay, everything will be fine. I won't focus on it and it'll get all better. Some people have bigger issues. Mine is just emotional, so it doesn't matter. Not true. All of this emotional and psychological is actually physically affecting the brain. And so, yes, it depends when it happens, how it happens, and how you deal with it, how it affects you. The brain and the body, when they are overstimulated, they become overwhelmed, which means your nervous system then needs help to be able to return to equilibrium because balance is disrupted. So again, as we had said in the last with the regulation, the last slide of 3 hours, once we get to the point of understanding where we are and we're calm, then we can learn grounding coping skills that can help get the nervous system back to equilibrium. But if you're untreated and there isn't somebody to work with you on returning balance, the individual tends to stay in stress response mode and can be triggered very easily, can be extremely stressed, and get physically exhausted from constantly fighting these battles. And so that's why it's important that trauma not go untreated. And then, finally, we talked about triggering before. So cues such as smells. It's not even certain loud noises. It can even be like a quiet noise. It can be anything that reminds the person of that previous situation. It could be triggering or add to a re-traumatization. This is the brain on the left of a typically developing baby. You see the colors, the bright reds, and the green there in the temporal lobes. And then we look at a child who is exposed to neglect, trauma, and abuse. And this was a significant amount. This slide is from 0 to 3. So there are studies to go along with this if anybody is interested. This particular child was significantly abused. We're not saying someone who gets yelled at a few times or someone forgets to pick up their child from school, they are not going to have this in their brain. But you can actually see the physical changes in this child's brain because of the trauma and the long-term neglect and abuse that they were exposed to. So babies, children, and we're also talking about babies and children in the womb. So from development, from, fetal period, from up until about age 3, it's pretty significant how trauma affects the developing mind. Not only, as you saw in the last picture, the brain looks different. There's less action and in some of the synapses, trying to make this as easy to explain as possible. So if there are too many experiences in AB, negative experiences, trauma, the ACEs, what have you, the baby's brains actually start to be primed to expect pain, to expect fear, to think that something bad is always about to happen. and their brain's developing. So here we go with the rewiring of the neural pathways, because this is how the baby thinks it's supposed to develop. It's in a situation where it has to protect itself, that every time somebody walks away, they're not sure they're going to come back. And so this baby, a child in this situation is starting to prime itself for lifelong trauma and almost thinking that fear is normal. And so they're going to react this way because, again, their neural pathways are going to be rewired with the situation. Now, if babies have had this negative situation, and let's say, this has happened to a 1.5-year-old and they were adopted when they were almost 2, so like the first year and a half, that actually can be helped. You can, again, rewire the brain, but from a positive aspect, you can build more synapses, rewire the neural pathways to be positive reactive. When babies have the support of those loving adults after traumatic events. So let's say there was a traumatic event in a home with those strong protective factors, with that loving, caring, attentive individual, mother, father, caretaker, then those babies actually have less damage and they're more likely to recover from the temporary damage, which means that it won't be long lasting. Whereas babies who don't have that support of loving adults after traumatic events tend to have more of that lasting damage. As we saw before, the brain is affected. We saw in the picture of the brain. There's also the shrinkage of the prefrontal cortex, which is up here. This is the response that you're responsible for mood, emotion, regulation, and most importantly, rational thought. And this is what happens when somebody is stressed all the time and that amygdala is going off and being overactive and saying, we have to respond to an emergency. And instead of actually responding to an emergency, because it's good if there is an emergency, but if there isn't, this amygdala is still doing this, and the prefrontal cortex is like getting smaller and not participating in the brain activity as much as they should. And so now emotional regulation is hard, rational thought is more difficult, and there's higher order processing, like problem solving skills start to get slower. There's under functioning. The defense mechanisms jump up, and again, cortex, your hippocampus is shrinking, and the hippocampus has to differentiate between your past and your present. And with this abuse and trauma, as the hippocampus shrinks, this is why a lot of times people feel like they're getting pushed back. Is this PTSD? Is this something that actually happened previously? Again, that differentiating between the past and the present becomes more difficult as the hippocampus shrinks because of the trauma. So it all kind of plays on each other. The easiest way to remember, not that you have to memorize different parts of the brain, but the lower parts of the brain take over, the greater the fear. So somebody is scared and kind of blocks out everything, that means their body is still able to breathe, right? All of those like reptilian functions, you can breathe, you can swallow, but your rational thought and your emotional regulation is on the back burner. That's that lowest part of the brain, which is developing first in the brainstem, as you all know about how the brainstem develops. It's about the first sonogram. You can already see it. This is what you kind of go back to when there is such great fear or trauma or pain or something that, again, is kind of blocking out anything else. So you let those low parts of the brain take over just for survival. Different brain states. Time again. Make sure. Does anybody have any questions before we go on?
Emily had a question before.
Halfway through. Sorry.
Emily had a question before.
Oh,
I'm not sure if
yes.
you're gonna
I'm sorry,
answer.
Emily. I couldn't see.
So she asked, I'm assuming the questionnaire referring to ACE is something you give only once, or how do you retest like a functional outcome measure to see if scores improve?
Unfortunately, you can give it multiple times, but there is no scoring for that. I would, if you're interested in comparing previous scores, see, I don't think from a scientific perspective, it probably doesn't make that much of a difference because it's an adult saying these things happened before I was 18. So unless you are remembering different, it should not change. Everything that's in the ACEs is something that happened previously. So if it's something that's in the past, it's not like an EPDS where, that'll change every time. I mean, you could give it multiple times, especially if you're dealing with somebody who may have repressed memories, somebody who may have blocked out things intentionally or unintentionally. I think that would probably be the only time, because otherwise, if they are able to address all of those issues and they're aware of all those issues that had happened before, they're not going to change. Because even if there's new issues, those wouldn't be their childhood experiences. Those would be their present adult.
So you just won't retest. Like you test first, you address.
Yeah, the only time I would retest is again if you have somebody, which does happen. There are repressed memories. There are times where people intentionally block things out, and then after they have a baby, remember because of the feeling of the baby crowning, maybe reminded them of a sexual abuse situation. So at that point, and if they start talking to you about, yeah, I had forgotten, but I think I was harmed when I was a child or what have you. Then and of course at that point, it would be helpful to do it again, but it just kind of to get a general feel for the adult's past, what type of childhood they had, what could have influenced how they feel now.
Okay. Thank you.
So looking briefly at the different brain states, we know that an individual's behavior is influenced by what state their brain is in, and the trigger occurs. If your sensory information is coming in and being processed, so you hear something, you see something, you smell something, this is your sensory information. As your brain processes the information, it then organizes it and tells you what to do. So if you're in a calm state, this is an ideal state, obviously. You're able to have abstract thought, right? And then it goes, I don't want to spend a lot of time on this, but as I noted previously, the more scared you are, the less abstract thought, focusing, and concentration you're going to have. So, then we get alert, which we're like, okay, I can only do concrete thought. Then we're going to get alarm. When your limbic system takes over at that point, you're just having emotional thought. Then when you get actually scared, you're fearful, your midbrain takes over and it's just reactive thought. And then, of course, the highest terror, we know it's the back down to the brainstem, which survival's the only focus. And it's only reflexive. Your sense of time also changes. And the reason I included this is because as a doula, it's important for you to understand if your client is feeling like in a terror situation or in a fear situation or even an alarm situation, your thoughts are going to get shorter. You're not going to be able to think further out. You're going to lose your sense of time, especially in a terror situation. In a fear situation, your midbrain's taking over, and you may think about different things that affect you. But again, let's go back to the calm. Your prefrontal cortex is going to be allowing you to just think about the past, think about the present. You can do a mindfulness activity. You can think about potential things that'll happen in the future. You can't do that when you're in a alarm state or a fear state. And so again, keep this in mind when you're talking to your clients, because if they're in this fear state, then they're not going to be able to have rational thoughts about the past or about the future or what have you. We're halfway through. Since we're not in person, if somebody wants to go ahead and take a break now, I can give you guys a few minutes. If everybody would rather we just go on. Show of hands, anyone?
How's
What do you
everyone
think?
doing so far? Would you like to keep going? Do you need a break?
If we could keep going, I don't know when my baby will wake up. So
Yeah, we can continue.
Okay. Okay. Again, if somebody needs to step away, that's fine. You could rewind the slides again once the presentation's done. We'll move on to 5. And this is where we take all that stuff we learned about trauma and put it more directly into the perinatal period. I know we've touched upon perinatal, but we had mainly talked about trauma itself and the brain. And so let's look at perinatal surrounding birth. So we got before pregnancy, we got during pregnancy, we got during birth, and then postpartum. Different types of trauma can occur during these different periods. We've got a quote from Dr. Bailey. I included this because it is pretty significant. The childbearing year can be difficult for trauma survivors, especially if the trauma was perpetrated by another person, as in abuse, neglect, sexual assault, household dysfunction, etc. PTSD is the most prominent long-term result of trauma, though it's common for survivors of trauma to also experience depression and anxiety. So for those of you without a mental health background, every time somebody has an event that can be traumatic, it may lead to PTSD, post-traumatic stress disorder. It may meet some of the clinical criteria, but not all of it. So even if somebody isn't diagnosed with PTSD, they could still have some anxiety based on that trauma. They may say, oh, I went to my doctor and they said, I wasn't having nightmares and I wasn't this, that, again, meeting the clinical criteria. And so my psychiatrist just brushed me off. What is important to understand is that even if they do not have something that is clinically diagnosed, they could still have symptoms. And those, symptoms are going to affect them, obviously, in a different way than it would if it was actually PTSD, OCD, clinical anxiety. There are different types of a lot of them are on a spectrum. There are different things that somebody may feel and may feel like they want to process. And as they're doing it, it's important for you to support them through that and, not brush it off like, oh, okay, well, if it didn't, meet all of these, criteria in DSM-5, then, you don't have to worry about it. It still bothers them. It's still, you could have depressive symptoms even if you don't have clinical depression. you could still have thoughts that are making you uncomfortable about, that happened before pregnancy, that happened because of during birth, or that may have happened postpartum. And those are still extremely important to discuss and to support and to acknowledge. So before pregnancy, there can be unprocessed trauma. Again, I had mentioned before, somebody may have issues that they don't want to talk about. They may have issues that they didn't address with anybody before, potentially from ACEs that had occurred and nobody ever talked to them about it. They may have grown up in a family where they didn't believe in therapy or what have you. And this can actually have a significant effect on a person planning to become a parent. It happens sometimes during the discussion phase. Sometimes it happens when they're actually planning, trying to conceive. Sometimes it happens in early conception. Often the brain is very interesting, and hormones, as we all know, kick up a lot in early conception. And sometimes people who have not thought about things in their childhood for years, decades, in early conception may remember something that had hurt them or scared them. There could be a resurgence of sadness or anger towards abusers that they know about, or caregivers. There could be a surprise memory. There could be, something that they did know about and they didn't expect to be angry, but now that they're becoming a parent themselves, this newfound anger can be rising. So ACEs, again, such as childhood neglect, post-traumatic stress, they can cause this resurgence of feelings, but they can also negatively affect fertility. So this is another reason that it's extremely important to address this and to work through it. Somebody may have this stress and have this anxiety and have this, hidden pain that they haven't talked about, or maybe they talked about it, but they haven't worked through it and they're having problems conceiving. Again, it is documented that there is a statistical influence from ACEs, between ACEs and fertility. So especially when these issues, these experiences are not addressed, it could have a significant impact on getting pregnant. Now, during pregnancy, common triggers include unwelcome touch, body positioning, sometimes just lying on the back. Midwives don't necessarily use stirrups, but some do. And, obviously in a hospital, typically it's back lying. So when we do this positioning, sometimes women feel uncomfortable. Sometimes that causes a trigger. Feelings of unwelcome touch. Sometimes a clinician who's not trauma informed won't ask permission before touching their patient. So this is why it's important, even as a doula, even though you're not doing a vaginal exam, putting your hand on their shoulder or touching their belly is intimate. So again, being trauma informed means that it's important to ask permission. You can even ask permission at the beginning and say, would you like me to ask every time I touch your shoulder? Or, when you're first determining the relationship, if they are in a relationship or they had something previously where they feel uncomfortable, you might have to ask every time. And then other times they may say, oh yeah, no, it's fine. You can always touch my shoulder. Just ask before you touch my belly or something. This is, again, why communication is extremely important. So just that lack of communication may cause that individual to feel as though they're disrespected, and just they don't have control, and that's right. As many as 1 in 5 women who experience a traumatic event develop the symptoms of PTSD during pregnancy. And I had mentioned that before. It does tend to happen, having these particular symptoms during pregnancy. When this occurs, if they experience trauma earlier in life, they are more likely to experience trauma during pregnancy. So if something happened when they were a child, maybe something happened when they were like in elementary school, and they experience a significant trauma in their life, they should be prepared, and you should be prepared to help them, because they may experience, they're more, statistically more likely to experience trauma during their pregnancy. Kind of one of those like breaking down. So moving on to birth trauma, that refers to the experiences or interactions or events related to childbirth that cause overwhelming, distressing emotions and reactions, which can lead to short-term or long-term negative impacts on health and well-being. And again, that short-term versus long-term often depends on the type of support, the type of understanding, the type of respect that the individual gets at that time. Again, all experiences of trauma are subjective, including birth trauma. 1 in 5 birthing people report experiencing some form of mistreatment during pregnancy or childbirth. And to some people, that mistreatment could be trauma. It's, again, subjective, very individual, but if somebody feels as though their experience in the birthing room or with a certain provider causes that overwhelming feeling, that distressing emotions, that is something that needs to be addressed. And, again, long-term or short-term health, psychological wellness, well-being can be directly affected. As I said, physical, psychological, something you feel because of the experience. It may not even be your body. You may have trauma because you have a newborn that needs medical attention. That is a traumatic experience. Baby could have been born with a health condition. Maybe the baby went right to the NICU and you didn't have a chance to see them after birth. That, again, can lead to trauma. Mom doesn't feel supported. Maybe she feels like she didn't receive the care that she wanted or needed during childbirth from loved ones. Maybe nobody showed up to help her, or from the healthcare team. Mom may feel that the healthcare team just wasn't there for her. And because of that lack of support, she could have trauma. She may feel control is actually one that is one of the most common complaints. The mom feels like she's out of control. People are telling her what to do and talking down to her and not allowing her to have a voice. That lack of voice and feeling that things are out of control despite your best planning and discussions can lead to trauma and can lead to additional issues after trying to explain what happened when there's nothing specific. It's just, I feel like I was out of control. I feel like, things were out of my hands. This is not what I wanted. Could be specifically not the experience you hoped for. It could be the reality of events didn't match up, and this may not be the caregiver's fault. This may not be, healthcare team or loved ones. They may be there trying to support you, but you had to have an emergency C-section, or, the baby, as I said in the first bullet, had to get sent to the NICU. Even that can lead to a mother feeling as though it's a traumatic experience. and that, again, needs respect and support just as any other type of experience. So we mentioned re-traumatization previously and what it is and how to help prevent it and reduce the risk. Re-traumatization, as opposed to healing, can occur when the same situation occurs. So as we said before, an individual who had some sort of trauma before may relive the trauma. Instead of healing, they may be re-traumatized. Sexual violence survivors, again, we said laying on the back and unwanted touch, that may trigger flashbacks. But what we're trying to do with our patients is change that from a re-traumatizing event to a healing event. And this can be a time for growth. It can be remarkable growth and resilience. We understand that these survivors are being respected, did have real traumatic issues, but we want to be trauma informed. Means we want to understand what happened previously. We want to reduce the risk of that happening. And if we can, use this as a growth experience, a healing experience, helping them become more resilient. They're able to experience childbirth as taking over your body, taking your body back, life affirming, empowering, healing. And, according to the Ward study, the difference is usually in the sensitivity and awareness of the perinatal care provider. And so this is huge for the perinatal care providers. So whether they're doulas or midwives or whoever is with the individual, it is extremely important to understand that and to approach it from an empowering and healing perspective. Birth trauma itself can lead to a range of maternal mental health conditions. We noted before, anxiety, depression, PTSD, among others. There are some numbers at you. 4 to 6% of birthing individuals experience PTSD. 17% experience post-traumatic stress. So that's not the meeting the clinical criteria, but still having some sort of post-traumatic stress. Psychological distress and harm. Again, we know that this makes a difference in our reproductive health, decision making, physical, emotional. The other things that it has a direct effect on is it increases your hypervigilance, your fight or flight, your pain tolerance, your aggression, irritability, and decreases your memory processing. So again, that's that prefrontal cortex, your reality testing, your immune response, which means you're easier to get sick when you're feeling this trauma, and your body and emotional awareness. As we had noted before, communication, a person's perception of their experience is a huge factor in that birth trauma. You can also increase the risk of birth trauma with, or I should say, some factors that increase are trauma of a previous pregnancy. We already know ACEs, having a previous stillbirth or miscarriage, having previous abuse, which again falls into ACEs, which is why I mentioned that, and an individual with mental health condition, even if it is not related to birth, even if they did not have previous abuse or trauma, if just being diagnosed with mental health conditions, especially depression, anxiety, and PTSD, even if it has nothing to do with birth, will increase your risk for birth trauma. And statistically, I know we all work in birth, so we know women of color are at an increased risk for both poor interpersonal care and obstetric complications, again, increasing the risk for experiencing birth trauma. That is definitely something to be aware of. And then the last postpartum period. So There is an overlap between trauma and postpartum depression, but they are not the same thing. PTSD, which is the trauma, is triggered by exposure to an external event, reminders of that event. So as we said, something that happened, somebody mistreated you, or your baby had an emergency, and that event can be re-triggered. Your PTSD symptoms are evoked and maintained by reminders of that trauma itself, which kind of the way that it presents for your patients is a little bit different than your typical postpartum depression or baby blues. Some of it, again, is an overlap, but sometimes there's more re-experiencing of the trauma, which somebody may have nightmares, flashbacks. There's more anxiety, panic attacks, difficulty sleeping, which is always a hard one to diagnose because, who doesn't have difficulty sleeping after having a baby? But avoidance of people, places, and situations is a little bit more specific for the trauma, the increase in anxiety and panic attacks, and the hypervigilance specifically having to do with the trauma. Again, a little more of that specific presentation. When we're addressing trauma, suicide and overdose is the leading cause of death for women in their first year following pregnancy. And statistically, we're looking at about 225 deaths per year. This is Department of Health and Human Service numbers. I believe it was 2018 report that I was pulling, but it's every year tweaks a little bit different, but it's a lot. And a lot of this, again, is lack of support, lack of communication, lack of understanding, and lack of respect. Because a lot of women have trauma that are not addressed or acknowledged. So helping to reduce the suicide and overdose death rate is extremely important by understanding, by supporting, by caring. And then plus we know it affects attachment. We know it affects the baby as well as the mom. Between the parent and the child, so parent-child attachment, we've got breastfeeding that has a significant effect on the baby's development. So this quote from UMass Dr. Deckel is that an infant may become an unfortunate constant reminder of the birth trauma and trigger distress for the mother. So the infant's triggering the mother, but then the baby itself is having all of these symptoms, and feeling that and being around a mom who's scared is really difficult for the baby, but it's also very difficult for the mother to take care of the baby. So we do see that, again, maternal PTSD is strongly tied to having a difficult time taking care of the baby. And this is typically because somebody who has PTSD, that reminder of that situation, constant reminder, is that baby. So let's move on to some prenatal practices that are perinatal practices that are extremely important for being trauma informed. Making sure that you give patient a control for green light, red light, tell them, whatever, start and stop. If they are feeling uncomfortable with too much touching, even if they say yes, then let them know, okay, even if you say yes, you can say stop when you feel uncomfortable. Make sure they know that. Keep that communication open. The word study does suggest provide a female provider. That is because it is statistically relevant that a female provider provides a calmer atmosphere for a woman, especially when doing vaginal checks and breast checks. But that may not always be the case. So that's, again, communication, keep this open. But entering your patient's room, make sure you introduce yourself. I'm sure you all know this. The eye level, if they're sitting down on the bed, sit down, chair next to them. It's that whole, when we talked about earlier, why people feel that they've had a horrible birth experience, that disrespect is one of them. So that communication, enter the room, tell them who you are. Don't just, I'm in charge. Allow them to have a support person there. Allow them to have, a support stuffed animal or something. Give them a suggestion, something that makes them feel calm and comfortable. And that can even be for the checkups. When doing labor induction, this is more focused on the midwives training that I did, but start with the least invasive methods of labor induction and go, as we know. Same with limit vaginal and breast exams as necessary. When possible, limit the number of people in the room. Now, certain hospitals have certain rules, but again, speaking to the audience as a doula, you're not going to be the one doing the exams, but you may want to step back because it might be overwhelming. Even though you're their support person, having 4 people in the room as opposed to, just 2 or 3 may be overwhelming. So you might want to walk out. Make sure you talk to them. Again, if you are the provider, the healthcare provider, so the OB or the midwife, ask them to remove clothing only when necessary, cover the patient between procedures. Again, opening, one of the big things is actually opening their legs. Ask them, if you need to do, whether it's a vaginal check or whether it's for birth itself and the baby's crowning, don't push them. Ask them. Ask them. Communication again, trauma informed care always includes communication. And also providing a full description. And this goes for doulas too. Anything that, might make them feel uncomfortable. Let's say, don't just grab their feet and start massaging them. Think, oh, well, no, it's a foot. It's not, a breast. It'll be okay. Like that may make people uncomfortable. So again, full description, explain to them what you're going to do in advance before you do it. And, potential discomfort and alternative procedures. If you, for example, are in a situation where you're helping to move a baby or something, that has to be explained because they will feel pain or discomfort. Of course. And again, what are we getting at here? Oh, 8:30 yet. We're okay on time. Trauma-informed care, as we had said, will acknowledge the pervasiveness of trauma. Focus on how trauma affects the individual's and that individual's response to their maternal care services and their health care services. And whether it's medical or whether it's mental health, understanding that from a trauma-informed perspective means that you're going to focus on how the trauma that they experienced affects the physical, the mental, the psychological, even the spiritual. It's going to have an effect. One of the keys with trauma-informed care is that atmosphere of trust. So again, communication, asking them before something happens and allowing them to talk, even if it's being quiet for a while. That atmosphere of trust makes a big difference. And that leads into the collaboration. Once you have that trust, you're actually able to have compassionate collaboration and work together. Trauma-informed care is strength-based. We're going to look at a patient's strengths, the positives. We're not going to look at, well, we want to avoid this and we don't want to do this and we want to, step around this. No, we want to focus on stuff. Yes, if something happens that they're not good at, instead of saying, well, you're weak at this, so, no, we're going to focus on your good point. Focus on the strength. Focus on, you can get through this because, yes, you may have had, such and such before, and that I respect that and I acknowledge it. But because you are so good at communication, you're so great at grounding, we've been practicing this grounding, focus on that. It's amazing what you can do from that strength-based, focus, informed perspective. Know that people may be having negative behaviors and understand and recognize that sometimes it's their coping skills that's all they had. Coping skills that come from a place of adaptation and survival sometimes look like negative behaviors. Blaming somebody for that can actually make them feel worse when they were just trying to survive. So, we're talking about a lot of these ACEs that some of your patients may have. Again, look at and understand that they may have a negative behavior, but they may have had to use that before they knew a healthy coping skill. So teach them healthy coping skills and strategies. Make sure, that trauma-informed care is going to strive to make choices for that survivor. Give them choices. Don't tell them what to do. Give them suggestions. Don't make them do something. And finally, being culturally competent is extremely important in trauma-informed care, as it is in any healthcare. But knowing that somebody's culture, there may have been, they're not allowed to talk during birth, or they must have, something covered or what have you. Understanding that it may have been, a cultural restriction for them, and that may have caused trauma. And so talking through it, working through it, and seeing what is appropriate for them now, and then allowing them to make that choice. When you're providing care to them, not only is it asking them and allowing them to make the choice, it's also making sure that you look at it from a perspective of what happened instead of what's wrong with you. Because when you look at somebody like, what's wrong with this patient? It's a completely different focus. You're not looking at it as what's wrong with them. They're looking at it as what happened to lead them. What happened in their past? What caused the, amygdala to be overactive? What caused them to be unsafe or scared? And ask them how you can help. And sometimes when you say, how can I help you? They have no idea. So give them a suggestion. What feels unsafe in here? And what can I do to avoid that? Maybe, knocking and then waiting before you open the door. It may be always allowing them to wear a t-shirt. But again, addressing that issue. What makes you feel safe? Is there something that I can do to help avoid that? What support do you need? Do you have resources? Can I connect you with resources? Again, this is something that, you should have in your doula tool bag if you have massage therapist or a psychiatrist, or you are doulas, but another doula, backup, different types of resources. We have at Florida Vita, we have trauma courses, resolve courses, and so that's like a 6-week program where work through different stages of your trauma, and you use different skill sets. So grounding, mindfulness, different types of talking therapy, as well as heart math, which is essentially understanding where in your brain the problems and issues are coming from and then working with them. So just to give you an example of things that we have right here at Data, as well as, having lists of local doctors, maybe having a psychiatrist and a therapist, and, things like that, that may help connect these individuals with the resources. And then also asking, what can I do? Or what do you like to do if you feel triggered? What is, do you go into turtle position? Do you close your eyes and picture your safe space? If you are working with them, it's very important for you to know, and you can help to make them feel safe. Sorry, this is a little blurry. It's borrowed from a study. But 5 guiding principles: safety, make sure they feel safe. They're somewhere where they feel safe. Choice, they have choice. Don't tell them what to do. Empowerment, feeling empowered. Let them feel empowered. Trustworthiness, building that trust, make sure that they trust you. And then collaboration. Again, you kind of have to build that trust before the collaboration, but collaborating with them. So it's not, I think you should do this, I'm telling you to do this. No, working together. And that leads to the empowerment. And that helps with the choice. And that helps them feel safe. So again, all these principles work together. Safe, in control, and validated. We've mentioned that a few times, but that is essentially the gist of trauma-informed care. Because understanding that they are validated, they're valid, their feelings are valid. And giving them a chance to explain too, not just say, "Oh yes, of course, everything you went through, I get it. You're valid. I believe in you," and then moving on. Not okay. Do you have any questions? Are you ready? You want to maybe take a break first, or is it okay that I start the procedure now? Or, hey, do you want me to give you a few minutes of privacy? Or, again, conversation, and making sure that because of that trust, they are able to talk to you and communicate back. They can ask questions, because a lot of times somebody won't remember. It happens a lot in prenatal visits, and you have to remind them it's okay to say, "I don't remember. You mentioned that, I'm sorry, baby sucked my brain. I can't think of what it was that you said." So let them know, so they don't feel insulted, or they don't feel like it's okay. Ask questions, even if there's no stupid questions. Ask me to repeat something, even if I said it 6 times. It's okay. Trauma-informed care, again, relationship building, forming connections. Self-care, which I'm going to go over quickly. So I really need to make sure that you guys understand how important self-care. Knowing how and when to self-regulate, teaching that to your clients as well. Understanding that link between trauma and mental health. And then also, again, speaking softly and gently and supportive. When we have that relationship, healing happens. Oldest medicine in the world is love and compassion. And this is a vice admiral and a physician and a surgeon general. So I kind of love that, because it's so true. We need to have that compassion. Healing happens in relationships, and trauma-informed care includes compassion, respecting human rights, understanding the prevalence and the impact of trauma, promoting safety and trust and diversity. So this is the self-care that I mentioned. Burnout. Please, I can go on and on about burnout, especially in the birth field, because we all get exhausted and have feelings of professional insufficiency and inadequacy. When you feel as though your emotional resources are depleted, it's important to focus on yourself as well as the needs of your clients. Because the needs of yourself, I mean, we all know, put the mask on first when you're in the plane. It's not going to help anybody else. But you got to listen to your own cues so you know. It's not as obvious as masks falling out from the plane. You have to listen to your emotional cues to your burnout. Sometimes people have personality changes, your own strengths and weaknesses, like Dr. Kaplan said. What happens when people get burned out? Their weaknesses get magnified. So you know what your strengths and weaknesses are. Keep an eye out, because if you can catch that at the beginning, then you're not going to go through this burnout cycle here. You have to make sure that before you get to that, hard work, low reward, then you're increasing the effort, and then you're getting rage, and then you're feeling despair, and then you're getting like a loss of belief in any future, and you're collapsing. We don't want to do that. So we want to catch it towards the beginning, when we're starting to do increased effort, even before that, hard work, low reward. Can't pour from an empty cup. And maternal care professionals, we know, are committed to providing their patients with the best care they can, especially when we're talking about trauma. And when you're in a situation where you're trauma informed, you have to be informed of your own issues as well. Maybe trauma, maybe stress, and maybe maintaining a healthy work-life balance. You may have issues with, reducing stress when you've got work that you can't schedule and you're not sure who's taking care of your kids and what have you. But when you approach that balance and you're able to address things better, you can better manage your stress, which means you can better reduce your risk of, as we know, you got chronic health conditions, heart disease, anxiety, depression. This comes from stress. So when looking at others, especially trauma, because unfortunately, the more traumatic a situation for your client, it has an emotional effect on you. So don't pour from an empty cup. Work on yourself as well. Select the needs of your patients. Set boundaries if you need to. So you get physical boundaries. Don't have somebody calling you all the time, or again, ensure that professionalism, respect. You got the emotional boundaries as well. It's very important, as you know, that there's a balance between empathy and detachment. So, your own emotional involvement, and this can help, especially dealing with those traumatic situations. It's hard sometimes hearing about child abuse or sexual abuse, something that, somebody may not have even addressed with anybody else before. And now they're in a situation where they're talking about their domestic violence from their first marriage or their abuse from their father. And it is hard as a healthcare professional to hear that. So again, boundaries, your professional boundaries, your time boundaries, right? You got your working hours, you get scheduled breaks for yourself, you've got your own limits. Make sure that you communicate those very clearly. So you understand that it's not just your responsibility or their responsibility, yours as well. And also seek help, self-care, maintenance, talk to colleagues and mentors. These boundaries, they define what you are, what you don't want to be. They show the end. A boundary shows where I end and somebody else begins. So you want to make sure that you have a sense of ownership and a sense of freedom. And boundaries, a lot of times people think that's a bad word, I don't have boundaries, I'm open, loving, and caring. And you can only be so open and supportive without supporting yourself too. So again, healthy boundaries, ownership and freedom, and your own empowerment. as well. Smart self-care. We know we avoid toxic relationships, assertive communication, take time to breathe. I won't go too much into that. Debbie is amazing with that. So there are different types of, relaxation strategies and different types of healing that can really make a significant difference. And then, of course, your self-care, you got to touch on your physical and your mental, right? Your emotional, so gratitude, journal, your spiritual, and that doesn't necessarily, mean church. It could be meditating. It could be going outside in nature. It could be going to church, or temple or whatever that fills your spiritual need. And then there's the intellectual, environment, social, and financial. I don't want to spend too much time on this, but making sure that you do address all of these types of self-care. Again, more self-care. All right. A little bit shorter, not quite, but anybody have any questions? Okay. Unless, Debbie, you see something that I don't see there. I'm not seeing any hands or anything.
Hello.
Oh, hi.
Hi. Was just looking for the place to unmute. Thank you so much for this
No
beautiful
worries.
session.
Absolutely.
There's definitely a lot of information to process. My name is Lila, by the way, and hello.
Hi.
So I
Nice to
joined a
meet
little
you.
bit, I had some complications, and also through the day, I have my daughter with me, so I wasn't able to like fully participate in the material, and it's so rich in information and in wisdom. Thank you so much. I just personally came out of my first doula client experience, 36 hours, just returned last night at 7 p.m. So I'm still like in this kind of the world, and also like sitting on how to process things and integrate in myself so that it doesn't become trauma for myself. So because as someone else's, participating in someone else's experience, where at some place they just have to be on their own and like fully, like you cannot do anything here, like you really have to trust them, like, and so many, like it's not your birth that you would do, right? And so many ways like could become, and then also like finding what the boundary is between yourself and how to help them. And so if you have any advice, and you did already mention something, but if you have any advice for the first care after the birth, like, or something like this, like first, like your three main rules, or like how you do it for yourself or something like this, the things to address at the top level in the next few days, as much as, time allows.
Absolutely. And I think that you made some very good points. And it's true that, I was talking about boundaries, but it's also the fact that you're experiencing the birth from your perspective, but you're not the one who's going through the birth. And you may be thinking, oh, if it was me, I would do this, or if it was me, I would do that. Or, something may be traumatic for you in that birth that's not traumatic for them. And vice versa. There may be, a mom who is like, they took the baby away right away, and that either bothered you and didn't bother them, or vice, as I said, vice versa. It may have bothered them, and you're like, oh, it's okay. They're just going to the NICU. They have to be checked out. So I think number one is knowing that what happens to them is their experience, and that's their story. You have to always have your own story. Your story, what you feel comfortable with, doesn't have to overlap with that. So after the birth, I would say journal, do something that's meditative. So, if it's like go out in nature, something that, hits you spiritually. I usually say do the top, the mental, physical, spiritual, emotional, try to hit all of those and focus on yourself because that's your healing. Again, back to your story. Wow, this mom was so incredibly brave. I would not have chosen, a C-section, but she chose it because, she was at that point and that was her. And I accept that for her. And then again, go back to your healing stuff. So the emotional, the physical. So I'm going to go for a walk. I'm going to have a nice cup of tea in front of the fireplace. I'm going to journal a little bit. Do all the things that hit those points of, emotional, physical, mental, psychological, spiritual, and make that a process, make that part of your, post birth, because then you're always addressing yourself as well. So anything that happened at the birth, it allows you to process that. Hopefully that helps a little.
Yes, there's definitely a lot, and regardless how aligned the birth and the birther is with the doula, there's still it's a wild experience, and it requires closure for a doula, regardless of how it went beautifully or whatever. It's like, it's meeting face to face with someone's like deepest sexuality and all the trauma that are so, like kind of just like right there, and then like your own stuff. It's really beautiful, and definitely requires a closure. Thank you so much for your
Absolutely.
wonderful session. Very timely for me. And another question I had, if maybe you mentioned this at the beginning, because I didn't join right at the beginning, is it recorded and will it be available in some sort of slide form or just like a video format, audio?
It is being recorded, and I will forward that question to Debbie because I don't know how to access it. What have you? That's through Florida Vida.
Yeah, the recording will be available to you, and the slides, as she's sharing, the slides is in the screen. Not
Wonderful,
the
thank you.
slides, not the physical slides, but the slides that she shared in the screen.
Right.
Yeah.
Wonderful. Thank you so much. I will definitely be listening.
Of course.
Thank you.
And then if Emily, Crystal, or Patrice have any other questions or any insights that might have come up during the presentation.
No current questions at this time, but will you provide us an email in case we have any like follow-ups that, are we able to like have access, Jill, to you at any point outside of
Absolutely.
this? Okay.
Yes.
I'm sure, Debbie, when you post the presentation, you can add my email on, or if
Perfect.
you want me to go through you, that's fine. Sorry, I was going back to this because this is our nice summary at the end here.
Just to make a comment, something I shared a lot with the doulas at their training, is that ask questions to the client that is trigger for them, that sometimes we think it's okay to say, like, oh, everything's gonna be okay, everything's fine. So I always like to address what are the supportive sentence for them that they like to hear, and what is the trigger ones that, like, please don't say everything's gonna be okay or everything is fine, because that can also be a trigger. So it's something that it's also involved in informed trauma care.
That's a very good point.
All right, ladies, if we are good here, I guess we can conclude our presentation. Jill, thank you so much for all the information, resources, all the data that you brought in. It helps to visualize. It was very eye-opening to see the beginning of the presentation where you compare the main addictions or diseases that they have in the body, how things can just the ripple effect from traumas in the physical body. So it's very interesting. And again, very subjective. And the key word that you brought for us is respect and respect ourselves. So it's
Absolutely.
the paradoxical world that we are in. But again, I'm glad that we are in community and welcoming Patrice to this moment with us from, another state. And thank you so much, Patrice, to joining us. If you all have any questions, please feel free to answer once I share the presentation and the recording with you, ladies. Okay, thank you.
Thank you, everybody.
Thank you.
Thank
Thank
you. Have a great night.
Thank you.
Thank you. Good night.